Thank you very much for having me. So, dear colleagues, my name is Martin Kender. I am a neurosurgeon at Regional Hospital in Zlín, but I'm also member of LERCO virtual reality team, which is a new research center in Ostrava. Our project brings together 9 different research teams across biomedicine, natural science, and maybe physics. It may be one of the projects. So our mission is to use virtual and augmented reality to allow students and young doctors to practice high-risk surgical steps safely, repeatedly, and without consequences before they ever perform them on the real patient. This work is only possible thanks to our multidisciplinary team, neurosurgeons, scrub nurses, and IT developers. Today, I will present our first experiences using virtual and augmented reality in neurosurgical training. So let's start with a quick question. How many of you have seen Spielberg movie Ready Player One? In that movie, people enter a fully digital world where everything around them is virtual. That's exactly what virtual reality is. In our case, an entire operating room, patient instruments are simulated, allowing trainees to practice safely and repeat procedures without any risk. On the other hand, augmented reality is different. It keeps the real world visible, but adds digital guidance on the top, like projecting anatomical structures or showing the ideal trajectory during a procedure. So simply put, virtual reality is digital and augmented reality is real with add-ons. First, we start with virtual reality. We use MetaQuest 3 headset, which is wireless, portable, and does not require additional hardware. To ensure realism, our virtual operating room is built from real photos and videos of our surgical theater in Zlín. Even the instruments are modeled after exact sets we use daily. Each simulation begins with OR configuration and structured briefing covering indications, anatomy, patient-specific MRI and CT data, and potential complications of the procedure. Then comes the interactive training. Learners follow a guided step-by-step sequence. Visual panel shows the current task. Correct instruments are highlighted. Progress is gated, meaning users cannot proceed until step is performed correctly. And if an error occurs, the system provides immediate audio and visual feedback. Our first module, vertebroplasty, served as a proof of concept. We started with basic prototype for use on navigation in interaction, as you can see in the first video. Over time, it will evolve into a current version, which include precise needle trajectory guidance, correct instrument sequencing, and we've also added simulated fluoroscopy. The students must use C-arm to virtually find the correct pedicle entry point. So now I will video. It's speed up. It's not so fast in real life. Okay, our next module trains the placement of intraparenchymal or intracranial pressure monitor. The learner performs the full procedure from identifying coherence point, then to drilling, opening the dura, inserting the probe, and final calibration. The focus here is on accuracy, correct sequence, and anatomical orientation. Our next step here is to expand this into a full external ventricular drain placement. Next module trains anterior cervical discectomy and fusion. It includes exposure, decompression, and stabilization with cage and plate fixation. In decompression phase, we simulate a surgical microscope, allowing high magnification for precise discectomy and end plate preparation. To enhance realism, we integrate simulated fluoroscopy, enabling verification of correct level and implant positioning, just like in real surgery. We currently improving anatomical realism, especially modeling critical soft tissues like carotid and esophagus. It is still running. Okay. These next two modules are still under development. First one is carpal tunnel syndrome. We already have an anatomical model with proper position of the hand. We are now implementing the guided procedures or procedural sequence. This will include local anesthetic, infiltration, precise skin incision, soft tissue retraction, and finally dissection on transverse carpal ligament to decompress the medial nerve. And the second module, our newest one, focuses on craniotomy. The simulation began with realistic patient position using the Mayfield clamps. The user is then guided through key initial steps such as skin incision, burr hole placement, with emphasis on current sequence and technique. What makes this module unique is the shift from guided training to objective assessment by introduction of a new concept called gamification. We track performance using measurable parameters like completion time and number of errors. This allows us, this scoreboard approach allows learners to monitor progress, and it actually increases student motivation. They want to beat their previous time and reach expert level stats. Looking ahead, we plan to expand in several directions. We will introduce emergency neurosurgery modules, such as evacuation of epidural and subdural hematomas based on our craniotomy template. Then we aim to standardize competency metrics across all modules. And then we would like to change VR controller for haptic feedback gloves to simulate realistic touch and instrument handling. And now augmented reality. We use Magic Leap 2 headset and we combine it with 3D printed vertebrae. This setup allows us to train highly precise procedures, in our case, screw placement. We project entry points and trajectory guidance directly onto physical model. At this stage, it is just primarily focused on preclinical skill acquisition. Our experience shows that these technologies are not meant to replace mentors. Instead, they enhance training by making it safer through risk-free practice, more consistent using standardized protocols, measurable with objective performance data, and scalable thanks to affordable and portable technology. Our experiences with virtual and augmented reality are supported by multiple international studies which show real measurable benefits for surgical training. For example, research from Yale University in Imperial College London demonstrated that residents trained with VR perform 29% faster and in operating room makes 6 times fewer errors compared to traditional methods. In short, the future of neurosurgical training is learning safer, smarter, and more reliable. Thank you for your attention.